Greetings, my dear students. With you, Mona Talab. I'm Associate Professor of Clinical Hematology, and our lecture today will be divided into two parts. First part will be erythropoiesis and general aspects of anemia, and the second part of the lecture will be iron deficiency anemia. Hematopoiesis is the process of blood cells formation. Hematopoiesis is divided into three lineages. Erythroid lineage, which is responsible for red blood cells formation, myeloid lineage, which is responsible for white blood cells formation, and megakaryocytic lineage, which is responsible for platelets formation. First, we have the hematopoietic progenitor stem cells, which then divided into multipotent stem cells, and then further divided into lymphoid progenitor cells and myeloid progenitor cells. Lymphoid progenitor cell will further subdivided into B cells, T cells, and natural killer cells. However, the myeloid progenitor cell give rise to the white blood cells other than the lymphocyte, I mean the basophil, eosinophils, neutrophil, monocytes, together with platelets and red blood cells. These are the stages of erythrocyte formation in the bone marrow. First, we start by stem cells, which is hemocystoplast, which then differentiate into proerythroplast, then erythroplast, which is early and late erythroplast, then further differentiation into pronormoplast, normoplast, early and late, reticulocyte, and lastly the erythrocyte or the mature red blood cells. The reticulocytes. Reticulocytes give rise to mature enucleated erythrocyte after 1 day of circulations in the peripheral blood. Though differentiation, nucleoli disappear, nucleus condense, and finally extruded. The cell size is reduced and large amount of hemoglobin are synthesized. Here we can see that before the stage of erythroplast, the differentiation and maturation of cells depend upon the erythropoietin. However, the erythroplast and then after depend upon the iron. These are important red blood cell values. We will start by the hemoglobin, which is about 13 to 16 gram per deciliter in males. However, they are 12 to 15 gram per deciliter in females. We have also what's called packed cell volume or hematocrit value, which is the volume percentage of RBCs in blood, about 40 to 45%. We have also the red cell count, which range from 4.5 to 5.5 million per cubic millimeter. We have also the reticulocytic count, which is 0.5 to 2.5% of the cells, and the absolute number of reticulocyte ranges between 50 to 150 per cubic millimeter. Then we have the red cell indices. The red cell indices are mean corpuscular volume, mean corpuscular hemoglobin, and mean corpuscular hemoglobin concentration. Mean corpuscular volume is the average red cell size, which range between 80 to 100 femtoliter. We have mean corpuscular hemoglobin, which is the average amount of hemoglobin in each red blood cell, range between 27 to 31 picogram per cell. And lastly, we have mean corpuscular hemoglobin concentration, which is hemoglobin density, or defined as average concentration of hemoglobin per red blood cell. They range between 32 to 36 gram per deciliter. The primary function of the red blood cells is to transport oxygen from the lungs to the tissues and organs in the body. So the red blood cell mass represents the oxygen carrying capacity of the body. The normal red blood cell lifespan is about 120 days. The hemoglobin molecule. Each red blood cell contains several hundred millions of hemoglobin molecules, which transport oxygen to the tissues and organs, as we just said. They contain about 250 million molecules per cell. The red blood cell specification, that the red blood cell are biconcave in shape, they have no nucleus, and the red blood cell contain the hemoglobin, which is the oxygen carrying molecule, and each RBC's molecule contains about 250 million molecules per cell. Each hemoglobin molecule contains 4 globin chain, 2 alpha chain, and 2 non-alpha chain. In the center of each hemoglobin molecule we have the heme molecule, and in the center of each heme molecule we have 1 atom of iron. So we can see that each hemoglobin molecule contains 4 globin chains, 4 heme molecules, and 4 atoms of iron. So we have 3 major types of hemoglobin. I will start by fetal hemoglobin, or hemoglobin F, which contain 2 alpha chain and 2 gamma chain. It's about 70 to 90% of hemoglobin at term, and then start to decrease by the first month progressively to reach less than 1% after 6 months after delivery. We have 2 types of adult hemoglobin. Hemoglobin A, which contain 2 alpha chains and 2 beta chains. They represent 97% of adult hemoglobin. We have also hemoglobin A2, which consists of 2 alpha chain and 2 delta chain. They represent 1.5 to 3 or 3.2% of the adult hemoglobin. So these are sites of erythropoiesis. Sites of erythropoiesis divide into 3 stages. First, from the 3rd week until the 3rd month of gestation, the erythropoiesis occur in the yolk sac. In the mid-fetal life, from the 3rd to 7th month of gestation, liver, spleen are responsible for hematopoiesis, specifically erythropoiesis. And in late fetal life, from 5th month of gestation and until delivery, and then after delivery, the bone marrow responsible for the erythropoiesis. So these sites of breakdown of the RBCs. We will start by the extravascular breakdown, because this is the normal site of the breakdown of the RBCs. However, the intravascular destruction occur in specific disorders, such like the intravascular hemolysis. So the breakdown of the RBCs occur in the macrophage of reticuloendothelial system, liver, spleen, and the bone marrow. The hemoglobin will be released from the red blood cell, disintegrated into heme and the globin. Globin is amino acid used in the protein metabolism, and then the heme will be further disintegrated into biliverdin and the iron. Iron will bind to the transferrin to be used in the iron metabolism, and the biliverdin will be converted into bilirubin, which are 2 types: the unconjugated bilirubin and the conjugated one. The conjugated bilirubin will conjugate to the liver and then excreted in the stool in the form of stercobilinogen. Part will be reabsorbed and excreted in the urine in the form of urobilinogen. Anemia. Anemia, defined as reduction in the hemoglobin RBCs concentration of the blood below normal for age and sex. According to WHO, adult males considered anemic when the hemoglobin less than 13 gram per dl, and adult females considered anemic if the hemoglobin is less than 12 gram per dl. These are causes of anemia, which may be results of impaired RBCs production or increase the rate of RBCs destruction, immunologic disorders, nutritional deficiency, and lastly as a result of broad spectrum of systemic disorders. So we'll shift to the classifications of anemia. We can classify anemia according to the etiology and according to morphology. Etiological classification: first, anemia due to a decrease in the red blood cells formation. Decreased in the red blood cell formation may be due to decreased in the bone marrow function. For example, aplastic anemia. Aplastic anemia may be congenital or acquired, and the acquired may be idiopathic or secondary to disorders such like infection, drugs, and immunological disease. We have bone marrow infiltration by abnormal cells, for example, leukemia, lymphoma, multiple myeloma, carcinoma, and so on. Another cause of anemia due to decreased red blood cells formation due to decrease in the substance essentials for hematopoiesis. We call them deficiency anemia. For example, iron deficiency anemia, vitamin B12 deficiency, and folate deficiency anemia. We have anemia due to excess red blood cells loss in the form of post-hemorrhagic anemia and hemolytic anemia. Hemolytic anemia, as you see in this figure, may be hereditary or acquired. Hereditary, usually intrinsic red cell defect. For example, defect in the membrane, as in cases of hereditary spherocytosis, elliptocytosis, or ovalocytosis. Defect in the enzyme, for example, G6PD deficiency, pyruvate kinase deficiency, or defect in the hemoglobin, for example, thalassemia and sickle cell disease. We have also the acquired hemolytic anemia, which is usually the result of extracorpuscular or environmental changes. Can be further classified into immune, autoimmune, or alloimmune hemolytic anemia, drug-induced hemolytic anemia, red cell fragmentation syndrome in the form of thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, disseminated intravascular coagulation. We have March hemoglobinuria, infection due to malaria or clostridium, chemical and physical agents, secondary to liver and renal disease, and lastly, one of the a genetic acquired disorder of hemolytic anemia called paroxysmal nocturnal hemoglobinuria. Other causes of anemia may be due to endocrinal disorders, renal failure, liver disease, and collagen disorders. These are causes of anemia, which may be results of impaired RBCs production or increase the rate of RBCs destruction, immunologic disorders, nutritional deficiency, and lastly, as a result of broad spectrum of systemic disorders. So these are causes of microcytic anemia, and you can see in cases of microcytic anemia, the MCV and also MCH, MCHC are reduced. Causes of microcytic anemia are iron deficiency anemia, which is the most common cause of microcytic anemia, thalassemia, sideroblastic anemia. We have also anemia of chronic disease in 2/3 of the cases. We have also lead poisoning, another rare causes, hemoglobin E disease, hemoglobin C disease, unstable hemoglobin, vitamin C deficiency, and lastly, paraneoplastic syndrome. Normocytic anemia, in these cases, MCV, MCH, and MCHC are within normal range. The causes are hemolytic anemia except thalassemia, which is microcytic anemia, hemorrhagic anemia, precisely the acute blood loss, because chronic blood loss results in iron deficiency anemia, which is basically microcytic anemia. We have aplastic anemia, which is actually pancytopenia, and the anemia usually normocytic normochromic anemia. Bone marrow infiltration by leukemia, lymphoma, or multiple myeloma. And oppositely, we have bone marrow suppression by chemo or radiotherapy. Anemia of chronic disease is normocytic normochromic in 1/3 of the cases. Renal insufficiency may cause normocytic normochromic anemia due to erythropoietin deficiency. And lastly, we have mixed deficiency. So we'll shift to the classifications of anemia. We can classify anemia according to the etiology and according to morphology. Etiological classification, first, anemia due to a decrease in the red blood cells formation. Decreased in the red blood cell formation may be due to decrease in the bone marrow function. For example, aplastic anemia. These are most frequent variation in the red blood cells morphology. The clinical manifestations of anemia depends upon the speed of onset, the severity of anemia, age of the patient, and underlying disease, especially cardiovascular system. However, general symptoms of anemia are usually not specific. For example, dyspnea or shortness of breath, weakness, lethargy, lassitude. A CNS manifestation is basically non-specific in the form of headache, a lack of concentration, maybe depressed mood or sleep disturbance. Cardiovascular manifestation occur in the form of palpitation, and in old age the patient may experience heart failure, angina, or intermittent claudication. Now we go to the signs of anemia, which is basically the pallor may be due to anemic cause, and we have also non-anemic cause. Pallor is usually elicited in the palm and the palmar creases, in the palpebral conjunctiva, in the nail bed, and the inner surface of the lips. Regarding the cardiovascular system, the patient may experience a tachycardia, sometimes hemic murmur. Specific characterization of pulse may be in the form of water hammer pulse, because anemic patients have what's called hyperdynamic circulation. Sometimes the patient may acquire edema lower limb due to increased capillary permeability, or in cases of old age due to heart failure. These are most frequent variation in the red blood cells morphology. So I will skip this slide, will be discussed on. This is the types of extravascular hemolysis, as we just discussed, in which the RBC destruction occur in the macrophage of reticuloendothelial system, and we have what's called the intravascular hemolysis. In intravascular hemolysis, which is pathological problem, the hemoglobinuria is the most prominent clinical signs of intravascular hemolysis, which differentiates it from the extravascular hemolytic anemia. Plasma hemoglobin is normally filtered through the glomeruli and actively reabsorbed in the proximal tubular cells, where it's catabolized with the release of iron in the form of hemosiderin. When kidneys reabsorption capacity is exceeded, clinically significant hemosideриnuria occur, and acute renal failure may occur during severe episodes of hemoglobinuria. Intravascular hemolysis occur in paroxysmal nocturnal hemoglobinuria, in severe cases of sickle cell disease and thalassemia, severe autoimmune hemolytic anemia, pyruvate kinase deficiency, or G6PD deficiency. We have thalassemia. We have two types of thalassemia according to the type. Alpha thalassemia due to actually deficiency of alpha globin chain, and beta thalassemia due to defect in the beta chain, and this is usually due to gene mutation. Beta thalassemia, which is more common than the alpha thalassemia, there is reduced beta globin synthesis. This results in excess release of the alpha globin chain. This results in insoluble alpha globin aggregates, which precipitate in the erythroblast, resulting in abnormal erythroblast. These abnormal cells are die prematurely in the bone marrow, because this is considered ineffective erythropoiesis. And if some of these cells escape the bone marrow, they will be released in the peripheral blood and then destroyed in the spleen, and this results in anemia. Anemia results in hyperplasia of the bone marrow to counteract in the hemolysis. So hyperplasia of the bone marrow resulting in hyperplasia of the skull bone. That's why patients with thalassemia have what's called a thalassemic facies, which is pulsing of the frontal and parietal bone, depressed nasal bridge, and the prominent maxilla. And due to excess iron, due to either increase the iron absorption which result in systemic hemochromatosis, and also due to dependence of these patients on the and the blood transfusion, this result in increase in the iron overload. So these patients have iron overload because the chronic transfusion therapy result in accumulation of iron first in the reticuloendothelial macrophage. The reticuloendothelial cell generally safe sink for iron, since reticuloendothelial cell macrophage keep iron sequestrated. However, and after large accumulation, there is spill over into parenchymal cell, which led to organ damage. Organ damage due to precipitation of iron in, for example, the pituitary gland, resulting in hypopituitarism, hypogonadism, precipitation in the thyroid and parathyroid gland, resulting in hypothyroidism, hypoparathyroidism, deposition in the liver and spleen, resulting in more enlargement of the liver and spleen, in the pancreas, resulting in diabetes, and they are called bronzed diabetes relatively to the bronzed color of the skin due to deposition of iron in the patient's skin. And also I have to say that the patient may have osteoporosis and arthropathy due to weakening of the bone due to hyperplasia of the bone, resulting in flattening or weakened in the bone cortex. So these are the manifestations of thalassaemic patients. This is the X-ray of a skull of a patient with thalassemia, resulting in what's called hair on end appearance. This is due to hyperplasia of the skull bone, and this is the thalassaemic features we just discussed, which is passing of the frontal and parietal bone, depressed nasal bridge, and prominent maxilla or prognatism. Sickle cell anemia due to presence of hemoglobin S instead of hemoglobin A, which is normal hemoglobin in the normal situation. However, in abnormal situation, for example in hypoxia, in dehydration, in case of infection, resulting in polymerization of the red blood cells taking the sickle shape. Sickling of the red blood cell resulting in obstruction and occluding the small blood vessels, which result in sickle cell crisis. Among the signs of the sickle cell anemia, there will be what's called the leg ulcer. Leg ulcer in sickle cell anemia due to basically vascular stasis and local ischemia due to sickling of the RBCs in the small blood vessels. According to the investigations done for cases of anemia, first we have to see the CBC and then figure out the type of anemia, whether microcytic, normocytic, or macrocytic anemia. Next step will be requesting reticulocytic count, which is basically from 0.5 to 2.5%. If the patient have reticulocytosis, this indicates hemolysis or hemorrhage, or sometimes patient under treatment. Reticulocytopenia, usually due to bone marrow failure or bone marrow infiltration by abnormal or malignant cells. Pancytopenia means a decrease in the white blood cells, hemoglobin, and the platelets, and these are the differential diagnosis of pancytopenia we need to know and memorize well. Aplastic anemia, hypersplenism, bone marrow infiltration by abnormal cells, megaloblastic anemia may be viral infection, paroxysmal nocturnal hemoglobinuria, hypersplenism, myelofibrosis. Sometimes we have to go for bone marrow aspiration for cases of pancytopenia and refractory anemia to rule out bone marrow infiltration by malignant cells and in cases of bone marrow fibrosis. Okay. In cases of microcytic anemia, I need to request iron profile. Iron profile in the form of serum iron, serum ferritin, total iron binding capacity, or sometimes we may request transferrin receptors and transferrin saturation. Basically, in patients with iron deficiency anemia, the iron profile in the form of serum iron, serum ferritin, transferrin saturation will be low, increase in the total iron binding capacity. So these are causes of microcytic anemia, and you can see in cases of microcytic anemia, the MCV and also MCH, MCHC are reduced. Causes of microcytic anemia are iron deficiency anemia, which is the most common cause of microcytic anemia, thalassemia, Okay. In cases of normocytic anemia, I have to request a reticulocytic count. I may go for a bone marrow aspirate to rule out or to confirm the aplastic anemia. In this case, we may see decrease in the cellularity of the bone marrow, decreased or suppressed hematopoietic cells with increase in the fatty spaces. And for cases of hemolytic anemia, we have to know or we figure out the markers of hemolysis, which are increase in the indirect bilirubin, increase in the stercobilinogen, increase in the urobilinogen, increase in the LDH level, of course increase in the reticulocytic count, and decrease in the haptoglobin. These are considered markers of hemolysis. Sometimes we may go for bone marrow aspiration, and in this case we will find hypercellular marrow with erythroid hyperplasia. So after confirming the hemolytic anemia, I may go for further investigation to confirm the type of hemolytic anemia. For example, I may go for hemoglobin electrophoresis for the hemoglobinopathies, as we just said, for thalassemia and sickle cell anemia. For hereditary spherocytosis, I may request osmotic fragility test. For G6PD assay deficiency, I may request G6PD assay. For acquired cause of hemolytic anemia, a direct COMS test for the autoimmune hemolytic anemia, and HAMS test for paroxysmal nocturnal hemoglobinuria. For patients with macrocytosis, first for megaloblastic anemia, I may request serum and RBC's folate level and vitamin B12 level. In this case, the bone marrow will show megaloblastic changes. For non-megaloblastic anemia, I have to rule out the liver disease by liver function test, viral markers, abdominal ultrasound. For screening for the patients who are suspected to be alcoholics, I may go for thyroid function test, T3, T4, and TSH. For patients with a pernicious anemia, which is a specific type of megaloblastic anemia, I may go for Schelling test, sometimes a gastric function test, and gastric biopsy. Okay, I hope this lecture is satisfying. I'm ready for any questions, and please send me on my email if you have any inquiries, and have a nice day. Thank you so much.